Welcome, everyone. We're going to get started in just about a minute or so. Welcome, everyone. It is my absolute pleasure to welcome you to the 2020 RCPA Conference, Vision 2020. So just as a reminder, you are in workshop L10, Creating the New Normal, Sharing Perspectives on Safely Opening During COVID-19. Just a few housekeeping items that I wanted to go over with everyone. Just a reminder that you've come into the session muted. There are two areas that you'll see on your screen. One says Q&A, the other says chat. Please be sure to put any questions that you have in the Q&A section. I will not be able to monitor the chat, so any questions need to go in Q&A. The way we're going to handle questions today, after each section, we'll have time for maybe one or two questions. Beyond that, then we'll save questions for the end. So if you have a question in there, we will get to it at some point during the presentation. Again, just a reminder that all of the workshop handouts and any slides that have been provided are available in the app in the agenda speaker sections. Evaluations are so crucial for you to complete too. We ask that you complete your evaluation after each session. And don't forget, there's an overall conference evaluation as well. You can access them in the app, the mobile app, as well as on a desktop if you're on the web for the conference. So please give us your thoughts, give us your ideas. We share the evaluation results with our presenters. The conference committee uses the evaluations to build a better conference for you for next year. So please give us your thoughts about that. Anyone who wants a CE, the electronic verification form, can be found on the RCPA conference website. And just a reminder that it has to be returned by October 8th to Sarah Eister via email. And for those seeking human resources continuing education, either through HRCI or through SHRM, you'll find the code for the approved sessions in the description of the session on the app. Again, just another reminder, all certificates of attendance as well as the CE certificates will be sent via email after the conference. All of our sessions are being recorded, so the live sessions will be available as well as the on-demand, at least through October 8th. So with that, I am going to turn our session over to Julie Weaver, Susanna Giese, Madge Dombrowski, and John Stahl.
Welcome, everyone.
Thanks,
hi. I'm going to go ahead and share our presentation and get that set up for us.
Okay, welcome everyone. Thank you for joining us this afternoon. I'm Julie Weaver and I'm with Community Services Group. As you heard, we have Madge Dombrowski with us, who's with Meraki, Susanna Giese with Venango Training and Development Center, and John Stahl with Cambria County Association for the Blind and Handicapped. I also do want to mention that you should have all of our email addresses in the handout so that after the session's over, if you think of some questions or want some information, please feel free to email any one of us and we'll be more than happy to try and answer your questions. So again, welcome. Our goal is to hopefully identify some effective strategies for developing and implementing a plan for safely reopening your services, to talk about some necessary communication needs, strategies to support the individuals and the staff during the reopening process. We'll of course share some of our pitfalls and challenges, as well as some lessons learned and new practices that we developed during the reopening transition. And we'll share how changing needs were managed throughout the reopening process. Next slide is great. As I said, I'm with Community Services Group, and we're in 19 counties in central and northeastern Pennsylvania, and we offer both mental health and IDD services. On the mental health side, CSG does offer a full array of mental health services with the exception of inpatient care. The mental health services will be the focus of this presentation, primarily group-oriented and facility-based programs such as outpatient, partial, psych rehab, clubhouse. The other presenters will also talk some about mental health services, but they'll also focus a lot on the IDD service system in terms of reopening. So in terms of your reopening plan, you do need to establish a comprehensive reopening plan for each of your services, locations, because there will be nuances and differences among them. For Community Services Group, we first start to reopen some of our programs in mid-May, and that's when those counties went into the green phase. I do want to point out that although some of our physical sites closed, such as the clubhouses and the psych rehab programs, none of our services closed. We immediately went into virtual services, and we had staff at all of our facilities. And programs such as outpatient, case management, supported housing, those folks, like the outpatient program, the building was open. So although they saw most of the individuals virtually, if there was an emergent situation, there was always someone that could see someone face to face. The same was true in case management and supported housing, even clubhouses and psych rehab. If there was an emergent situation, a person would be seen face to face. So you need to prepare the individuals and their support systems for what a reopening will look like. So perhaps you could give them a virtual tour of this space. You could do that by either doing a video and sending it to folks. Perhaps you could do a Google Meets or a Zoom, whatever platform you're using, and actually walk around your space to show the individuals what it will look like. Physical space is a normal to us, so that individuals will be affected by the fact that your physical space is going to look different when they come in. So it is important to try and prepare them for that. Maybe you could try a soft opening. We did do that in some of our locations. Where facilities were within walking distance for some of the individuals, before we had our official opening, we did invite them to come to the program and to help us reorganize the space, design what the space needed to look like with the 6-foot social distancing, etc. That way they really had some ownership for it, and they could also talk to their peers about what the program was going to look like. It's important to send out a letter outlining all the guidelines that must be followed. You need them to know that they're going to need to be masked, that they are going to be social distancing, that there's going to be a lot of sanitizing going on, a lot of screening going on. Make sure you have all the necessary supplies. I'm sure everyone at this point has all the PPE that they need. For some of our programs, we took baggies and put pens, pencils, hand sanitizers, those types of things in the baggie and labeled it with the individual's name. And that was their possession. It stayed at the program, but they had that for use every time they were at the program. That way we didn't have to continually sanitize pens and that type of thing, but they had them for their use. Also, be prepared for the individuals to be tired after a short period of time. At least for us, a lot of our individuals over the last number of months have not been very active. They've been spending a lot of time just sitting around. So just the fact that they have to get up, get dressed, get out of their residence and travel to a program and then engage in a program is exhausting. I don't think we really kind of anticipated how tired they would be after a short period of time, but that is something that you definitely want to keep in mind. So now that you've prepared the individuals to return, you need to prepare your staff to return to in-person services as well. You're going to encounter the full array of attitudes from staff about reopening. This can be a challenge when the staff are not quite ready to see the individuals, and there does need to be a balance that needs to be struck between needs and wishes. So you are going to need to spend some time kind of figuring out what that's going to look like and how every specific staff person is feeling during the reopening phase. While we were closed, we deployed some staff to residential, so we had to bring those staff back. So that although we did a lot of virtual work and all of our buildings had staff in them, we didn't have enough work for all of our programs for all the staff to be working full time. So some of them did go into some of our residential programs to help out. So you need to reorient those staff to the new normal of their program. And also you want them engaged in designing what the new normal is and learning all the new processes and protocols that you've put in place while they were deployed. Try to have your processes outlined for everyone as simply and completely as possible before you open. It's never going to be perfect. It's always a work in process, and you're going to have to be changing things as you reopen, but you just need to go with what you have. You also might want to try a run through, do some role playing as if individuals are there in the program and staff are there, because your staff really need to know what you're expecting of them once you reopen. They need to know all the processes that you need to have in place, all the sanitizing that you're expecting it to be done and when it's going to be done. So you need to make sure they're clear on all those policies. They need to know about the masking, the social distancing. And for us, part of our protocol was every hour, everyone had a 5-minute break and everyone was expected to wash their hands and sanitize the area where they were. So it was helpful to run through that with the staff so that they were clear on how that happened, how that was going to occur, and also the screening of the individuals as they arrived. Do some team building with your staff for the reopening. Let them know what a great job that they're doing. Do something to help build their confidence, and let them know that they can lean on their peers as well as their supervisors to get through this, that everyone will be working together, that everyone will be trying to do the best that they can just to help allay any fears that they might have. And obviously maintain a sense of humor. That helps everyone get through things. Some additional considerations: transportation. Coordinating with transportation vendors is important if you're not transporting. You need to know what their guidelines are. What are their protocols? Are they going to be spacing the individuals on the vehicles? Are they going to require masks? And do they have masks if for some reason an individual shows up and does not have a mask? We actually took supplies of masks to some of our transportation vendors so that they would have masks to hand to individuals if for some reason they did not have them. If you're providing the transportation, you need to have all the protocols in place that you want in terms of seating and in terms of the sanitizing of the vehicle. Make sure your drivers are very clear on what your protocols are and comfortable with them. If they're going to be doing the screening, which is what we did have them do, so that if someone came to the van, our van drivers took their temperature and asked the screening questions. So make sure those drivers are clear and know, what do I do if someone doesn't come with a mask? What do I do if their temperature is above the threshold that's been established? Or if they answer yes to one of the questions, they need to be really clear and really comfortable on what they're to do when those situations arise. Schedules was a huge time sucker, I guess you would say. We had people like all of you do. They come to the program 3 days a week, 4 days a week, 5 days a week. Well, with the social distancing, we realized we wanted to try and get everyone in 1 day a week to start. So what are you going to do for the person who was coming 3 days a week? They're going to come 1 day a week in person. Are you going to still offer a hybrid? Are you going to allow them to do virtual programming the other 2 weeks? Excuse me, the other 2 days. Also, of course, you want to poll everyone. Are they ready to come back? We obviously had some folks that, although we were green, they weren't ready to come back yet. So you need to know who's coming back, who's not, and juggle your schedule to see how many people you can get on any given day. In terms of computers and copiers, how are you going to protect them in terms of multiple people using them? Are you going to have a keyboard cover for your computers that you can sanitize after every use? Are you going to use saran wrap over your keyboard so that you can throw it away after every use? I know there's a lot of controversy around how the virus is spread, but we still maintain that we sanitized everything. So you just kind of need to think of everything that someone is going to touch and how you're going to make sure you get that sanitized. How are you going to manage the daily screening? Are you going to have one doorway and entrance, one doorway and exit? Are you going to have someone sitting by the door that's going to do the temperature check and ask the screening questions? Make sure, again, that they are comfortable with the questions, that they know the protocol if someone answers yes or has a temperature above the threshold. In some of our bigger programs, we did get thermal scanners so that someone wouldn't have to necessarily be there taking their temperature. But there are other protocols that need to be in place with that. So just know how you're going to manage the screening. Are you going to open full days or half days? We had some of both. Some of our programs opened full days to start, and some decided to go with half days. Again, the half days was decided because of the individuals they were serving and realizing that at least initially to have a mask on for the entire day would be too much. Also, the whole meal food situation in some programs where we make the food or make the meals, we decided when we were opening it would be easiest not to have to deal with food to begin with. So they opened half days, didn't have to deal with the food. Once that they felt comfortable with that and everyone was doing well with that, then we expanded the hours and introduced managing the food during this time as well. Communication. We always know we can never communicate enough. For CSG, our executive leadership team met daily during the bulk of this so that we could make decisions quickly, answer questions quickly, change protocols, change policies, and get that communicated. We also established a medical advisory committee, and that group also met daily. They were the ones that really handled anything in terms of anything that dealt with anything medical. So it was a lot of, I think this person was exposed, what will we do? And they communicated daily as well. They followed all the CDC guidelines, the Department of Health guidelines, and kept up to date with that. So the programs had daily huddles with staff to keep everyone informed. So daily, they were aware of any changes that were coming company-wide. In terms of the daily huddles, they also talked about what happened yesterday that worked well, what do we change, so they could do all of the tweaking that they needed to do day to day. And also just to support one another. If a staff person was really struggling or they realized an individual was really struggling, they could talk about that and come up with a plan to kind of keep everyone on an even keel as much as we could. I know you're all communicating with your counties, your residential providers, and other stakeholders. For us, some of the residential providers were not allowing their individuals to come back even when it was green. The state was dictating that they could not come back. So again, we were still deploying staff to go out to those residential individuals and try and meet with them outside to keep them connected or to do Zoom meetings with them. We also had a red, yellow, green, or still have a red, yellow, green document. Again, mirroring Governor Wolf's document of red, yellow, green. So we had red, yellow, and green for every one of our programs so that the staff could easily look at it and see what the program was to be doing during each one of those phases. It was just a nice little cheat sheet for the staff. Hang signs everywhere. People know about masking, they know about social distancing and sanitizing, but you can't have it hung too many places. It's really hard for everyone to keep that in mind all the time and remember what they're supposed to be doing. So just having it in front of them as much as possible was helpful. Challenges. As I said, scheduling was a challenge. So you have the number of people that you can have attend with the 6-foot social distancing, but then you're going to have no-shows. No-shows because someone has symptoms, is not feeling well. No-shows because they came last week, but now they're feeling like they really don't feel comfortable with being there in person. Maybe they used to come on Mondays, but so did Mary, but with a new scheduling, Mary isn't coming on Mondays anymore. So that's their friend. They don't really want to come until they can be coming the same day as their friend. Transportation. We have some transportation companies that didn't transport when we turned green. So how are we going to get folks in there? Fears and anxiety. The individuals have fears and anxiety, and so do all the staff. So it's just being aware of that, acknowledging it with everyone. You personally may have fear and anxiety around this. It's just kind of getting that out there and letting people talk about it. Masks and social distancing. It's not that the folks, when they came back, were going to hug one another, etc., but they were used to working with their peers side by side, to being next to one another. So we needed frequent reminders about the social distancing. Balancing between in-person and virtual. Some folks, once they came back in person, were no longer interested in doing any virtual. They wanted to come back all their days. So it's kind of explaining that and working through that with them. And same with staff. We know how exhausting it is to sit in front of a computer screen all day. So balancing it for them. How much are they going to do in person? How much are they going to do virtually? And then the whole challenge of groups. You have some of your group members back, but maybe not all of them. So are you going to have, in the same group, are you going to have virtual attendees as well as in-person attendees? And how are you going to manage that and make sure everyone feels included? Lessons learned. You have to be nimble, and that continues to this day. We're changing things on a dime, and we continue to change things as things in our environments change, things with the individuals and the staff change. So we just have to be ready to know that we're going to have to constantly be changing, that there's not going to be an end to that. Both staff and individuals will be exhausted. I know personally I was so surprised and couldn't figure out why at the end of the day I'd be so tired. But it is exhausting to be sitting in front of a screen. And when you're doing both things and juggling, doing in-person and virtual and shifting gears all that time, it's exhausting for everyone involved. And communicate, communicate, communicate. You can never say anything enough times. You feel like you're repeating yourself, but the more you say it, the more it gets integrated into your daily life. Any questions? Okay.
So far, I do not have any questions in the chat room or in the Q&A room. So if anybody has anything, if you want to pop it in there quickly, we can read it. Otherwise, if you think of something, we'll definitely get to your question at the end of the session.
Sounds great. We can move on to Madge.
Okay.
Okay, my video is on, but I'm not showing up. I'm from Marikey. My name's Madge Dombrowski, and I'm from Marikey, and we serve northeastern Pennsylvania. My area of Marikey serves northeastern Pennsylvania, the upper corner of the state, Lackawanna County. So pre-COVID, we had CPS services for people with intellectual disabilities and behavior support for people with intellectual disabilities. In CPS services, we served 26 people. Our services were community-based and facility-based. The vast majority of the 26 we served lived with their families or on their own. We served 3 people residential and 1 in life sharing who were with different agencies. We were very active in the community, and we had all functioning levels from people who were in the severe range of intellectual disabilities to the mild range. So activities for the community included Meals on Wheels. We delivered Meals on Wheels 4 days a week. Shopping for individuals in personal care homes, bowling, dining out, doing trips to parks, museums, zoo trips. We also ran a small snack shop in the building where the individuals would go and purchase items, package items, and sell them. Behavior supports, we have approximately 100 cases. We provide those services to people in their family homes, their work options, their CPS programs, and we have a contract with a residential provider to provide services in the residential facilities, community homes. During the shutdown, for CPS, because most of the individuals were with their families, we made weekly calls to the families and individuals to update them on the status of the program. And many times talking to the individuals themselves, particularly the individuals that lived with families, because they would be saying, I want to go back, I want to go back, and would need to listen to me tell them there's no one here. My staff were furloughed except for my program spec and myself, since we didn't have residential, and the ability to provide virtual services did not work. We contacted the individuals, and because majority lived with their family and we were in a rural area, they either did not have the technology or the families weren't interested in that because they would have to help them. We had regular contact with the supports coordinators, primarily by email, and weekly calls with our county AE. For the individuals, we found what they wanted, what they needed. We sent social stories to everyone and went over them when we talked to them on masking, hand washing, social distancing. We also prepared activity packets for the individuals, and they would say, you know, can you send me some puzzles? Can you send me craft activities? So they, on a weekly basis, so they were kept occupied. Behavior supports, remote services began, and again, it was primarily by phone. There were some Zoom and video conferences, but because people weren't attending their CPS programs and were home with their families, or the few that, or in residential facilities, many of them did not have access to Zoom or video. We did Zoom or video where we could, and we did the same thing by providing social stories, activity packets, talking to the families, coming up with ideas to help the people cope, and developing social stories on coping with the COVID shutdown. As we were preparing to reopen, next slide, please. As we were preparing to reopen, the behavior supports remained pretty much the same. However, the one thing that is happening now is if a person really needs a face-to-face contact, Marikey has developed a form that is approved by management to a safety plan, why they need the contact, what we expect to do. It is preferred to have it outside, how we will do it, what are the safety precautions that we will take. Preparing to reopen the CPS program. Marikey did not consider reopening until every county was in the green phase. Most of my services are Lackawanna County, which was one of the last counties with Philadelphia area to go into that green phase. Marikey developed a spreadsheet where each county COVID stats were reviewed weekly, and there was criteria that had to be met, a percentage of the population below of new cases, deaths, etc., before reopening was considered. And then it was a 3-stage reopening, and there were specific activities that were considered safe in stage 1, safe in stage 2, and stage 3, which needed approval. And we're not even into stage 3 yet. Stage 1 was primarily activities outdoors where people could social distance and be away from settings that might have a higher risk. We were assuring staff were trained in safety precautions and vehicle cleanliness. So prior to reopening, when we called staff back, and that was an issue because some of the staff said, we don't want to work with individuals, and decided that they would not return to employment. We started with the small staff, only a few coming back, and we spent several days initially training staff on the individuals, activities that were safe, precautions that would be needed to be taken, how to clean the vehicles. There is staff screening and temperature checks, a form prior to every staff at the start of the shift, if they're the COVID form. A van cleaning procedure was developed, printed, discussed, that would occur prior to people being picked up, prior to when people left, prior to the next individual being picked up, and at the end of the day. And it was a specific procedure that was developed and needed to be followed and was practiced at the beginning. We prepared van kits, which were basically a gym bag, which had hopefully everything you would need, because we were going to be doing community-based services. So there was the thermometer, Clorox wipes, spray disinfectant, hand sanitizer, gloves, extra masks, PPE equipment like gowns and goggles should it be needed, paper towels, bathroom tissue, plastic bags to put soil things in, first aid kit. Then all along we were trying to prepare families for reopening, but now when we decided how we were going to reopen, we spoke with families individually and where each individual was. Could they mask? How long could they keep a mask on? How were they with social distancing, hygiene techniques, and looked at how each individual was and what the time expectations could be. Then we explained our procedures to the families, which included the COVID screening and temperature checks prior to someone entering the van when they were picked up. And if someone had a temperature or answered the questions, what our procedure would be, the travel policy. As we started in summer, some people were still going on vacations, and if the state was on the list, the governor's list of travel restrictions, then we would not serve that person for 2 weeks upon returning. And our potential exposure policy. So what we would do for people if there was an exposure. Next slide. Reopening. We did not open until the first week of August. We had initially served 26 people, but we currently serve 13 people, all on a part-time basis. And just like Julie had said, the majority of our people were used to coming full days, 5 days a week, 3 days a week, some 2 days a week. And now that wasn't going to be possible due to staffing, the number of vehicles we had available. So it was a part-time basis. When we looked at each individual, what we found was for the vast majority, 3 hours with the mask was what they could tolerate. So that's where we began with those people. Marikey decided for their CPS programs that we would not provide facility-based, and we have not started facility-based yet. All services would be provided in the community and authorized into a 1-to-1 ratio. So a staff is taking out one person for that time frame every day. The criteria to attend for individuals was the ability to wear and tolerate the mask, the ability to social distance, and decent hygiene skills, hand washing and bathroom etiquette. We did not want someone who staff had to, and are not serving yet, have to provide too much hands-on care. There were 2 individuals of that 13 who, because of their safety issues and health, would not be safely served in the community. So we currently serve them in the 3-hour blocks in their home with staff going in, taking the temperatures, doing the screenings on the individual and families, and staff masking and doing as much social distancing as possible. So the majority of our individuals are served in a 3-hour block each day they attend. Each staff provides service to 2 people a day, sanitizing the van, again, at the start of the day between individuals and at the end of the day. And most individuals are receiving service either 2 or 3 days a week. The activities that are selected by the individual, but have to be those that are okay by Marikey's policy at this point in time and provide minimal risk. So the activities at the present time are primarily outdoor activities or places with large open areas and not too many people at this point in time, so social distancing is easy. To date, it's going relatively well. The individuals are all thrilled to be out, and we are not serving the people who lived in the residential facilities. Initially, we could not, as Julie said, the state said, but most of those individuals, well, the few we had right now, all of them don't really have the ability to wear masks and social distance, and their providers would prefer to serve them with their people that live in their household to maximize safety for them. Challenges. The challenges are occurring every single day. Things change. The weather is a big challenge. If it was very hot or rainy, finding places that were safe to go and trying to stay in outdoor places. Now, being in the northeast corner of the state, and it was 30-some degrees every morning for the last week almost. As it gets cold and winter's changing, we're looking into places and trying to keep people safe. A big challenge for the individuals, of course, was they were used to their routine, 5 days a week from 8:30 or 9 till 3 o'clock in the afternoon, and they had their activities, delivering Meals on Wheels, the same every day, and that just changed. And they're missing their friends. They were used to having their small cohort of friends that they spent time with, talked and socialized, and they're missing that. And of course, staffing is an issue. Finding staff and even attempting to hire staff, it was a challenge before, but it's more challenging. Our next steps are trying to increase the number of hours people attend and days they attend. Hopefully being able to provide community CPS in that 1-to-2 ratio, being able to social distance people on the vans and in areas, the people who can tolerate that. Continuing to find activities and hopefully volunteer placements that are safe as the weather changes, and hoping to open a small facility-based program as the weather changes for the individuals who cannot be out in the community as much, may have some medical issues or not be able to tolerate the weather changes. So, and again, the challenges change every day. Something new happens. We did have our first where staff went to pick somebody up and took their temp, and it was over 100, and had to say, sorry, but you cannot come to program today. And that was upsetting for the individual, even though it had been explained. Any questions, comments?
We do not have any questions in the Q&A, so we're good to go.
Thank you.
Thank you.
So I'm Susanna Beasley. I'm the Chief Program Officer for Venango Training and Development Center, and thank you all for coming to this session. And I'll be talking about some of the strategies that we implemented at our agency. We had a lot of similar experiences to Julie and Madge, but so I'll talk about some of the things that were different. Our organization is, we're mainly sited in Northwest PA. Prior to COVID, we were serving about 124 participants in community participation support through 2 licensed workshops, one of them in Venango County and one of them in Clearfield-Jefferson County in DuBois. We also had 3 licensed adult training facilities, 2 of them in Venango County and 1 in Clarion County. Serving individuals in-home and community supports in 2 counties, and serving individuals in supported employment in all 3 counties, and then also provided transportation services actually in 2 counties, Clearfield-Jefferson and Venango. We also operate Fairweather Lodges on the mental health side. Fairweather Lodges are supportive living for people with a mental health diagnosis or co-occurring substance use disorder, and included in those 7 lodges are a veterans lodge and a training lodge. And we also operate a drop-in center in Clearfield-Jefferson County with about 120, give or take, that we're utilizing the place per month. And then we operate competitive employment and business services through janitorial contracts, document scanning, and lawn care. We also operate a car wash. I did not list it there. And then we have MacroPack is our production organization, and it is competitive, but we also, MacroPack helps to provide contracts for our licensed workshops. So that kind of explains what we look like prior to COVID. During the closure, I want to say that our reopening strategy was greatly influenced in a positive way by the communication and the services that were provided during our closure. So one of the messages, all of the memos and letters that went out and phone calls really emphasized that this was a temporary closure, obviously intended for each person's safety and for the safety of our workplaces and programs. And so that was the message that was communicated. Our program staff that remained on staff, because we did lay off our direct service staff, when they were contacting families and individuals, they used a script to maintain that consistent message, and so that everybody was getting the same communication, and that also helped, I think. Remote services were developed and they began April 1st, and that really helped our staff to maintain contact with everyone and find out how they were doing. And during that time, they did spend some time reinforcing the practices of wearing a mask and talking about what everybody was doing during our shutdown. We resumed CPS as hub-only services in the yellow phase, and we did 1-to-1 services, but we also did 1-to-2 to 1-to-3 services during that time. We did make use of the allowances for greater than 1-to-2 to 1-to-3, but not until after we reopened, and I'll talk more about that later. Our training for returning to facility really began during those remote services too. So once the staff had come back, that's when they really started to started the early implementation of wearing masks and encouraging individuals to wear masks when they were on CPS, and screening, and then also cleaning in the facility. On the mental health side, they also maintain communication through remote services, usually phone calls or Facebook Messenger, but it was less formal, and it was a little more difficult to connect with those individuals. Not everyone had access to the technology. The lodges just instituted a no visitors policy. So our reopening plan really began with developing a team, and we called it the COVID-19 corporate team. And the team was comprised of our CEO, our CFO, myself, our operations director, our directors for community services, and also our facility and CPS services. And Also our mental health program staff were involved with that. But in addition to that team, all of the staff were really engaged in developing the plan. I have to say that at each site, the staff, program specialists and staff cooperated with our operations director in evaluating each site, looking at the operations, the resources, the processes that we would need to consider, what the communication needs were going to be for each of the individuals at each site, what training and tools for employees and participants, what would be needed for everyone to safely return. We used ODP's facility CPS readiness tool for our guideline. It was very detailed and it really served to kind of help us think through a lot of the steps. We set a target date for July 13th to reopen after the sites were completed with all of their preparations. We had information coming at us as well as everyone else at this time coming from every direction. So a large amount of our effort at that time was just trying to process all of the information that we were receiving. And at that time, we just began making decisions about what we were going to do for our plan. It really was a team effort, and it took everyone's effort. One of the things that we considered at that time is there was some uncertainty about face shields, when they were going to be permitted, and for who they would be permitted. So just decisions like that we were kind of, I think the phrase was being used at that time that the plane was being built while we were in the air. And that was certainly true when we were putting together the plan, but it all came together. On July 13th, we opened all of our sites. And one thing that we did is it was up to the individual's choice. If they wanted to come back, if their team had met and worked through their transition plan questions and considered everything, then they were able to return. We didn't stagger a return. We just invited everyone to return who was ready to return. So then the task was then determining who they were and who was left to still meet with them and find out what their return date might look like. So return dates varied by program site and also by individual. Our reopening plan, our written plan, really addressed 7 key areas, and those areas are exactly as pictured here: ensuring that sick workers would stay home, focusing on worker hygiene and PPE controls, social distancing or physical distancing has been better termed, making sure that everyone could maintain 6 feet apart during work and activities, the workplace cleaning and disinfection protocols, both for the facility and for vehicles, and staff and participant transition planning, our drop-off, pickup, and delivery practices and protocols, how to manage traffic inside the building, how to limit it, communications and training practices and protocols. So these were the areas that we covered. For our reopening plan strategies, for each of these 7 areas, we closely followed ODP's guidance, as I said, to allow staff and participants to maintain social distancing and follow all the recommendations. Our implementation plan began with bringing the staff back. We did use a payroll protection loan to bring our direct support staff and some of our janitorial staff back to work on April 27th, and we began training on reopening. The staff had about 4 weeks of training before beginning to provide community CPS. Late May, actually it was early June by the time we got everything worked out with transportation. So when individuals started to come back, and staff included, in order to maintain, to make sure that people were staying home if they were sick, we, in our letters and in our communication, really encouraged everyone to self-monitor prior to arriving. And that was just to limit that someone would present symptoms during an on-site screening. And so that on-site screening would just serve to verify that they were symptom-free. So that was one way we tried to prevent that situation from occurring. And then we used a phone assessment if somebody called in, just to find out if they were experiencing symptoms that were related to COVID, and we could go from there. We also instituted a staff multi-site work assignment disclosure form. It's a lot of words, basically just a form to help staff document and write down if they were working for another provider or if they were filling in at another site. So even though we're operating day programs, not residential, similar to residential, if we had somebody that was out or had called in and we needed to fill in staff, staff could work at multiple sites. And sometimes staff would work between mental health programs and our IDD programs as well. So something we did to demonstrate to everyone how we were maintaining the 6-foot physical distancing for programs and work, we invited the county administrative entities to come in for site tours. We distributed maps. When our plan was sent out, we sent out the plan to county AEs, to the group homes, to other programs, to our stakeholders, and maps were included with the written handout, with the written plan, so that everyone could kind of see how we were planning to maintain the 6-foot distancing for work and activity setup and program capacity. And how we did is we set up stations so that the staff, so the individuals would have a station, and similar to what Julie described, they would have a kit, both at the kind of prepared it and planned for that at the drop-in, but also in our day programs, that they had supplies that were unique to them, that they could be cleaned, and then the staff would just rotate between each individual. And in one of our programs, at least, the individuals would stay in those areas for lunch as well, instead of moving to another area for lunch. We established transportation drop-off and business delivery practices. So what was also involved in maintaining the cleanliness of our area was limiting the traffic coming in and out. So deliveries were made, delivery people were met outside, and we would collect paperwork and handle everything outside rather than people coming in the building. I skipped masks. So for cleaning inside, part of that was that we distributed masks upon entry, and then we collected those same masks. So if somebody had a mask that they were comfortable with wearing, they could bring an extra one with them. So they would ride on the bus and wear one mask, but when they arrived, they would have a mask that they could leave at the program so that we could launder and make sure everyone had a clean mask every day. And then we did emphasize training. We made a monthly, quarterly, and annual training plan. Something that we just were aware of is that maintaining this level of structure was really something new. I think Julie talked about, staff and individuals being tired, and I think this is how we addressed it. One thing we did is we scheduled breaks during the day to maintain that physical distancing. That was one way to try to give people a break with the masks and accommodate people needing to go to the restroom and getting a drink without running into social distancing. But we wanted to make sure that we did training, monthly training for the individuals. We tried to coincide it with our fire drills, and then quarterly training and annual training plans were made just to keep everything fresh for the staff. And then for our lessons learned, we had quite a few. In fact, prior to this presentation, I gathered a few more from staff, but the ones that I listed here, things were not the same. So schedules were either reduced or modified to ease the adjustment. Spaces were consolidated to support staff and participants and maintain coverage. That's a long way of saying that, and sometimes an individual would be used to working on a certain job in one area, and that area would be relocated. We're at about 50% in one of our workshops, and at another workshop, we're probably between 80 and 90% having returned. So with the fewer numbers in the one program, we have more individuals that were in group homes in that program, and so fewer have returned. And so it was necessary to consolidate some of our space. I talked about breaks and restroom use plans. These were big deals just to make sure that everybody could take a break and that we could still maintain that social distancing. So those were adjusted at each site to make sense for each site. And emphasizing communication with individuals and families surrounding their preferences. So when they came back, whether it had to do with CPS and where they would go during CPS or just their preferences, a lot of communication was really important. We found that for individuals that initially weren't ready to return, it was really necessary to maintain communication with them to make sure that they knew we're open, we're back, and continue to revisit them for their plan and their return date. Some individuals left their residential arrangement and moved in with a family member during COVID, and so communicating with those family members and making sure they were included in the team discussions. Travel policies were really critical, I think, to reducing time off for self-isolation and quarantine, so those were important. And then creating policies to allow for flexibility and consistency that allow staff to work from home, but making sure that it's kind of fair for everyone. Just real quick, a few that I added were that in one instance, having ratios permitted that were in excess of the 1 to 3 really starts to be helpful. One of our cafeterias, once we figured out how many tables would fit in there to accommodate the 6-foot distancing. If we were over a couple of people, they were able to then go out on CPS, or we were able to offer CPS to a couple more people. And so being able to do CPS with more than the 1 to 2 to 1 to 3 helped to maintain our social distancing in the facility at times. Staff said that individuals adjusted well, and in some cases we probably underestimated their ability to adjust. At the mental health drop-in center, the coordinator did find, or the assistant director there did find it difficult to engage everyone, as before. I mentioned that before, with limited access to technology. And also peer supports were suspended and are even still operating differently. And peer supports were kind of key to sometimes providing transportation to our drop-in. So I think that is everything I have. If there are any questions.
We do not have any questions.
Okay.
Good afternoon, everyone. My name is John Stahl, and I am the Director of Rehabilitation at Cambria County Association for the Blind and Handicapped. And you can see my information, contact information, and webpage information are located on our first slide. Okay, next slide, please. I'd like to give you just a little bit of background pre-COVID regarding our agency. We have 2 locations, one in Johnstown, one in Ebensburg, both in Cambria County. We offer 2 large facility-based programs licensed through 2390 pre-vocational licensing. And we also have 150 individuals that participate in facility and community-based services. We're a little bit different than a number of agencies in that we do not have direct contracts for work with other companies, but rather our CEO and board of directors many years ago took a different direction and decided to go into prime manufacturing. So we do our own products, we order our supplies, we produce our products. We have a sales team of 7 that go out across the country and actually worldwide to market the different products that we manufacture. Couple of the main things that we do make, we are the largest supplier in the United States of underground hangar systems for mines. We've also developed bracket hangers for solar farms. We do assembly of food service kits for hospitals. And we also have an industrial sewing department for which we produce state contracts with Unique Source. In our CPS community-based activities, our individuals, when they're not in the facility working or producing products, they're volunteering at various nonprofits. They're participating in social activities with community interaction. and really doing what they would like to do and to try to get them more into the community and develop the skills necessary there to be successful. We do have a very large unfunded handicapped employment program. We have 100 individuals between our two locations that we do not receive any funding for. And these individuals have a variety of disabilities, but their disabilities do not qualify them for the IDD services. So once COVID-19 hit, we, along with all the other agencies in the state, were affected by this. And in mid-March became first the ODP mandate of the furlough of our 150 CPS consumers. What we did at that point was had bi-weekly phone calls to the consumers, families, group homes, basically doing wellness checks and trying to provide updates to the best of our ability that we could do with, limited information on a weekly basis, or even when we could project that they would be able to come back. We also included updates on our webpage and also our Facebook page. Now, what we did also, we applied for a Payroll Protection CARES Act loan, which enabled us to pay staff that were furloughed. And we also made a decision to pay all our CPS consumers and all our non-sponsored handicapped employment individuals while they were furloughed. Now, during that furlough, as I said earlier here, it was very early in March, and actually later in the same week, Pennsylvania Department of Health and Governor Wolf issued their mandated health phases. So we also lost those individuals. Simultaneously at that time, one of the main issues we had were with our staff. A lot of them have school-age children. With the schools being furloughed and having to do remote learning, we had a number of our staff needing to take the FFCRA leave in order to stay home and school their children. Now, in terms of reopening, what we did, even though we didn't have a projected date, but we immediately began the thorough cleaning and sanitizing of our facilities. We had to come up with the reconfiguration of our lunchrooms, our production areas to establish the proper social distancing. We were able to get the PPE supplies that we needed. And in the reopening, which is on the next slide, we also began to bring back slowly a slow, methodical reopening of 5 non-funded handicapped employment consumers, the non-funded employees, in mid-May. We were able to do that because it was determined that our company was producing essential products that were needed. One of the main changes that we also had, we all wear many hats, as you all do, but in that initial time, the difficulty was being that we're a prime manufacturer and we were producing essential products, the orders continued and the demands to ship still continued. So a number of our staff all assumed production roles. We made sure that the online or telephone ISP meetings continued, and we developed our ODP Return to CPS plan. That was approved by the county, then submitted to ODP and was approved at that level. What we were doing then, once we entered the green phase, we were able to start to bring back our CPS or our funded IDD individuals into our facility. We had made a conscious decision at that time that we would focus on the in-facility before we would do community. We just felt that that might be a little safer and a little easier for us to control at this time. So that's the direction we went. So on our approximately July 6th, we started to bring, once again, a slow, methodical return, this time of maybe 5 CPS consumers at each of our sites every 2 weeks. Now, prior to those individuals returning, our program specialists by phone completed health assessments of our consumers. We talked to the families about prioritizing what individuals would not have difficulty wearing masks or would be able to safely return. and we set up our process to do that. Upon their return, and to this day, all our individuals are coming through one entrance where they do the COVID questionnaire. I have one of our program specialists at each site do the COVID questionnaire and also do a temperature check. Many cases we're able to meet the individuals at the vehicle, and prior to them exiting the vehicle, we're able to do the temperature check and start that process. Now, currently, we're only at about 60 to 70% of our CPS consumers back at this time, so we're continuing that reopening. On our next slide, some of the challenges moving forward. We continue to have our transition meetings with consumers, families, group homes, so we can show that we're safely bringing people back into our facility, and to also start to develop plans for community activities. We've also developed schedule accommodations that help our individuals return. We're still having some issues or concerns with some of our direct care staff positions, some turnover there. Some of our folks, while they were furloughed, were actually making more money on unemployment than they were with wages. And some of them have elected not to come back. So we don't have all the answers, certainly at this point there. We feel that we've been effectively doing our reopening at this time. Some concerns or challenges besides what I've mentioned so far is just difficulties. I think we have some individuals that either with their age or some pre-existing medical conditions just don't feel comfortable about coming back. We've had some concerns with some of our group homes kind of digging their heels in a little bit, and we totally understand that they need to advocate for, their consumers, our consumers, but feeling a little bit of resistance with that. All in all, though, I think it's been a learning process. We continue to learn each day new things to be more effective. We're constantly on Pennsylvania Department of Health's website, CDC, ODP, and we just continue to try to provide the safest opportunities we can for our individuals. Being now that I was the last person to present, I can take any specific questions, or if anybody has any questions for the group at large, we'll be happy to entertain them.
We do have one question. John asked for the residential providers, what are you doing about family visits?
Well, on the mental health side for us, with the exception of personal care homes who have their own unique set of guidelines and protocols, we are allowing for family visits. They have to be scheduled so that we don't have multiple families coming, and anyone who enters the homes or comes to visit, even if it's outside, we do screen everyone, so their temperature would be taken and they would be asked the screening questions. But then again, we have masks. So if they would come without masks, then we do still expect all the social distancing and all the other protocols and sanitizing and masking, but we do allow for scheduled family visits at this point in a lot of our mental health homes.
I could say the same for our Fairweather Lodges. We don't generally have families come and stay, but if they do, we do expect the screening and to follow some protocols. But on the IDD side, we ourselves are not a residential provider, but we just had a conversation this morning where a situation was described, and I kind of remarked about that a little bit, where an individual had moved home or actually moved in with a family member during COVID and had not yet returned to his residential arrangement. And I don't know if I really have an answer to the question, but I expect that it varies from residential provider to residential provider what they're doing. And at least in one instance, that provider communicated that if the individual, returns to the residential setting, or when they do, that they have not yet really outlined what they're going to do for the holidays and for family visits. So, we are heading into fall and winter and holiday season, and that is still something that they haven't completely sorted out. And they're kind of waiting to see how things go. So I expect it will differ from provider to provider.
Okay, we have another question. If a shutdown were to be enforced again, would you change anything that you did the first time?
Good question. One thing we learned that ODP emphasized is they really preferred that providers did not lay off their staff or have them laid off. One of the strategies that ODP promoted was looking to see if CPS staff or day program staff could be redeployed with residential providers. We did have conversations with at least one residential provider, and that did not come to fruition. There were so many details involved that by the time that was to come about, we were moving along and beginning to look at bringing our staff back as well. And we had redeployed some to other programs to fill vacancies with our Fairweather lodges and things like that. So
Yeah.
I don't know if we would do anything differently except to try to keep from furloughing staff.
I think with us, as I had mentioned, we did deploy some staff to residential. I think we'd look hard at that again and try and make that more voluntary. For some, it really wasn't an option. They had no choice. And I think that is one thing we might try and look at to see how we could accommodate them in their home program, unless, of course, residential was in crisis and really needed help. But that's the one thing I think we would relook at if this were to happen again. But other than that, I think we've learned a lot, but I think in terms of our reopening, we're pretty satisfied with how it went.
Yeah, I can speak on that also. Not that we're perfect or we don't have anything else to learn, but I think the approach that we took was very, very slow, cautious, and methodical. And I think now looking back in hindsight, we feel very comfortable. I think at the time when we were doing that, there was a lot of frustration that our staff was experiencing because of our phone calls to our consumers. They wanted to come back. We really didn't have information to give them to come back. And I'm glad we took the time that we did with the slow, methodical callback that we've done there. But I think our tendency might have been in the beginning, can we rush the process a little bit, but we didn't do that. So it really wasn't a mistake, but this whole thing has been a learning process. And as I said, I believe all of us are still learning, and all of you in the audience are still learning in this process that none of us have experienced before.
You do make a good point, John. One thing we would change if we kind of have to roll things back is our consumers did voice not wanting to get a call from their peer provider, their clubhouse provider, their outpatient provider. They were tired of getting multiple calls. So I think as a service system, we would coordinate with all their services and not inundate them with virtual phone calls or virtual meetings. We try and be more collaborative and coordinated with other providers so that it wouldn't, we wouldn't bombard the individuals in that way.
I agree with what everyone said, and we, like John, took a very slow approach. And with that slow approach, I am so glad we did. There were other providers that opened earlier, and we had calls with all of the providers every week with our county. So we learned from others' mistakes before we actually opened and got information, which was very, very helpful.
Okay. One more set of questions. What do you do with an authorization if a kid has to isolate or quarantine for an extended period of time? This is for PHP authorizations. Do you discharge and readmit or put the authorization on hold?
Well, we don't have child PHP, but what I do if it were an adult, so probably a child as well, is work with whoever the payer is, whoever is paying. We'd work with them to see what their protocols were for that, if we needed to put it on hold or discharge and readmit when they're not quarantined.
And we would work with the supports coordination agency to see what they and the county would want. And what they did initially for us is at the beginning of the fiscal year, they did not authorize anyone until we were decided to go back into service. But we still provided, you know, the calls, the packets, and attended ISP meetings, did the quarterlies, etc.
One thing I was going to answer the question before, communication obviously has been brought up, but we sent out letters and made phone calls to individuals and families, but the residential homes themselves, sometimes the program specialists would get the information, but communicating to every person at every level on the person's team with all the same information was something we could have done, I think, better. There were some cases where some people on the team, you know, still didn't know where we were because we were communicating directly with the individual or their caseworker, but not everyone on the team.
Well, I think that about wraps it up for us today. Thank you, everyone. Thank you to our presenters. It was wonderful. And everyone who was a part of the session, I hope you enjoyed it. And I hope you have a wonderful rest of your day.
Thank you.
Thanks, everyone.
Thanks, everyone.
Bye.
Bye.
Bye.